Anagha, who's the senior instructor for this course, and she'll be talking about post-refractive surgery. As you all know, that cataract surgery possibly is the maximum number of surgeries that are being done, followed by refractive surgery. Injections are obviously gaining ground, so there are going to be more and more patients who have had refractive surgery, right from radial keratotomy to LASIK, hyperopic, myopic LASIK. So how do we do cataract surgery in post-refractive surgery cases? The famous star had to go and get an explant done because he was a post-refractive surgery case and an IOL, whatever. So let's see how we can avoid that situation and how we can give the best results to patients who have had refractive surgery earlier for cataract surgery. Dr. Anagha.
Thank you so much, sir. So, like sir said, we have a whole lot of kinds of surgeries that we do as a refractive surgery spectrum. And all these patients are very demanding. They have an intolerance for diminished vision, and decision making in these cases can be tricky. So let's go over a few cases. So suppose you have a 40-year-old patient coming up to you for a cataract workup, and you find that the keratometric reading is quite flat, something like this. And when you do a topography, you see something like this. But what if the topography was this? So the difference that you see here is the central flattened area, which means that the patient has undergone a myopic LASIK earlier, refractive procedure. So the difference is that if you see the image simulation, the contrast sensitivity would be less. There would be higher corneal order aberrations, higher positive spherical aberration in this patient, and the image quality would be poor in the post-operative period. Now, in a very high volume OPD setting, it is very easy to miss edge of the LASIK flap. Like for example, in this case, can you identify where the edge of the flap is? And this patient has undergone a LASIK surgery. So unless the patient actually tells you or you ask specifically for the history, you can easily miss it. And the challenges are having a refractive surprise in the post-operative period. Now, eye trace here would actually help us to give what are the internal aberrations versus the aberrations from the cornea, especially if you have had a decentered ablation, which can give rise to something like coma. And the DLI index, which would help us to decide at what point of time the patient should ideally end up having surgery. So it's, you can get a hyperopia after myopic surgery or a myopic surprise after a hyperopic LASIK surgery. So what are the fallacies of the keratometer? Basically, here you are overestimating the keratometric reading from the paracentral area. So that means you are ignoring the flatter central region and underestimating the IOL power required, resulting in a hyperopic outcome. So there is a difference between post-RK and post-LASIK. So in post-RK, it's basically both the anterior and the posterior curvatures that are affected, and there is a small central zone. Whereas in LASIK, it's basically the anterior part which is flattened. So there is a difference in the back to front ratio, which basically causes the refractive surprise. So in post-RK patients, we are also aware about the diurnal fluctuation. So you need to take at least 2 or 3 repeated readings on virgin corneas, because there could be corneal edema and there could be changes in the keratometric reading. And usually there is a transient hyperopic shift in the early post-operative period, and a long-term hyperopic drift is also known, and that is why it's better to target myopia in these patients. Now we have advances in the IOL power calculation. So you have the ASCRS online calculators, the Barrett True K with the total K, or the Haigis L for the post-LASIK or intraoperative aberrometry. So this was a patient, a 50-year-old, having multiple cuts, and one of the flattest case that I've seen, almost 27 diopters, as you can see here. So on the ASCRS online calculator, the advantages, it is a combination of various, it is a combination of various IOL formulae, so that you can get the most accurate, and you have the average, minimum and the maximum IOL formula, and we usually take the maximum, or you can even target a 1 diopter or 1.5 diopter myopia as the case demands. Now, unless you are really alert, your technician or the optometrist who is doing the biometry can also make a mistake. For example, if you have selected untreated or not a post refractive surgery procedure module, or you have taken the wrong IOL formula, like here the SRKT in this patient, the diopter was 23, whereas actually a 28 was used. Also in these post-RK patients, it's sometimes if you have multiple close cuts, then you can have opening up of these cuts during or at the end of surgery. Now here, the mistake that I'm doing is, first I've taken a 2.8 millimeter incision, it should have been 2.2. And ideally you need to take a slightly scleral incision so that you prevent opening up of the incisions. Now as you can see here, as I'm doing the phaco, the main incision also has opened up. And not only that, you will see how even the side port is opening up. So it's very important in these patients to be taking the incision slightly on the scleral side, and you need to suture up these incisions at the end so as to prevent any wound leakage. This was the patient post-operative. Now, whether to do a toric IOL in these cases or not is slightly controversial, but I have done a lot of torics in post-RK patients. Now, for example, in this patient, again, the average IOL power was 16.6 and we used a 17.5, slightly with a slight myopic target. And you can see how in the second day post-op it's plus 2.5. But you wait for 3 to 4 weeks and this patient settled down because the transient hyperopia reduced. Post-myopic LASIK, basically it's the IOL power calculation that's most important. So here again we have used the ACRS online calculator and maximum was 12, we used a 12.5. You can see here if you use an untreated mode, then it gives you a plus 9 diopters. So you would have probably been left with a 3 diopter hyperopia. If you have used the Barrett suite, it gives you a 12.5, and the Haigis suite, Haigis L also 12.5. So you can use multiple formulae or even the Hill RBF so that you correlate with multiple formulae to get the exact IOL power. This patient did extremely well, 6.6 and 6. So you can use the advanced monofocals in these patients, but use of trifocals is usually very tricky. And even we remember the case of the celebrity, like Sir said, where an ADOF lens was used, so we need to be extremely careful in these patients. So this was an interesting case, one-eyed patient where RK was done and LASIK was also done subsequently. So you can see the RK cuts as well as the interface having the metallic deposits. This was the OCT of the patient. Topography was good, but you can see how the Pentacam Holiday EKR report, the graph shows a very extended keratometric high variability. Now the dilemma here was whether to use the post-RK formula or the post-LASIK formula. So the post-RK showed a 21 diopters, whereas the post-LASIK showed 23 and Haigis L was 27. So even with multiple readings, we got an average of the post-LASIK as around 24 with a maximum of 25 and RK was 21. So finally we went ahead with the 25. The patient also wanted flax procedure, so we went ahead with the flax. So the surgery itself was quite uneventful. So here with the flax, we just lift the, and here we took a slightly scleral incision. There was a free-floating capsulotomy, and the patient did extremely well. Fortunately, had just a minus 0.5 spherical, and he was extremely happy. Now, in the last case is a post-phakic IOL patient who came to me around 6 years or 7 years later. She was a very high myope with a IPCL from the care group, and she had a nuclear cataract. So it was not basically an immediate phakic IOL induced, but probably these patients also develop nuclear sclerosis over the years. Important to note in these patients are the optical biometry would give you readings without any changes. You don't need to make any changes because it's an optically clear medium. So here we have used a 1 diopter lens. So again in this patient, we had a flax procedure. Now this was a IPCL from the care group. So it's slightly more rigid compared to the ICL from the star. So many times if it's a very thick lens or a rigid lens like this, we thought we might have to increase the size of the incision, and that is why we decided to do the phaco before removing the IPCL. So I was sitting temporally, so I rotated the IPCL in the vertical direction, and I'm just now doing the phaco underneath the IPCL. Now you would note here how there is a radial tear in the capsulotomy. So it's been already, it's a known fact that if you're doing a flax in a post-phakic IOL patient, probably because of the reflection from the surface of the phakic IOL, there could be some radial tear, so you need to be extremely careful. So here, in such cases, because there is a radial tear, you should be careful to avoid any kind of fluctuations and sudden shallowing of the AC to prevent it from going to the posterior side, and always keep the AC taut. And this patient did extremely well. Post-op was 6/6 unaided. So you need to counsel all these patients with regard to residual refractive error and possible need for correction, in spite of taking all the necessary precautions, and that they might need even a repeat touch-up, and very rarely even an IOL exchange. Again, night vision issues and higher order aberrations could affect and compromise the quality of vision. So to conclude, in all these patients, decision making can be difficult. You need to have multiple options of IOL power calculations, and we can get excellent results in all these patients and hit emetropia. Thank you so much for your kind attention. So any comments and your thoughts, especially on the patient where you had both RK and LASIK done? What do you do in such cases?
Supposing the patient had a hyperopic LASIK and an RK, what would you do in that case? This is LASIK for myopia, right?
Yes.
So supposing he had a hyperopic LASIK, then what
So
formula?
you would know from the topography that it's a hyperopic LASIK. So you would not use a negative aspheric lens. You would use a positive, a routine IOL, because there would be a negative corneal spherical aberration. So that would be the type of IOL. But when you put in on the ASCRS online calculator, you have multiple forms. Like you choose the post-hyperopic LASIK and then put in your K1, K2 values, and then you can get the IOL power of the desired.
So broadly, whenever you're looking at a refractive surgery that has been done for myopia, specifically RK, you never hit, you do the TrueNet and you do that, but I always overcorrect a little bit more, and depending on the number of incisions or how flat the cornea is, that overcorrection from my side could go up to an addition of 1 in the power to about 3.5 in the power. But one thing I always tell the patient, I take it on the consent form, that residual refractive error can be the thing that will be left. I am not very aggressive in putting toric lenses, but in the few cases that I have put toric lenses, the results have been reasonably good. The only problem with the post-RKI is that there is fluctuation in the power, that means during the day and the night. So that is one, and there's, I don't know whether you have any experience, but a couple of cases of post-RK who had huge diurnal fluctuations, and obviously that's the power fluctuation also. I have done few cases of cross-linking and corneal cross-linking basically beforehand, so that toughens the cornea. Yeah.
For diurnal variation, I have put them on IOTIM and to nullify and blunt off the diurnal variation, and then take the K readings. And the second thing is do a two-step. Means the first step you make it aphakic, and then you calculate, do it. You can do it on an AR, the K readings, and then use the, do the routine biometry and then do it. So that's the other way of doing it.
Yeah. The also there may be a little difficulty, but if you had a flap LASIK done, you can always go back and correct it further if there is a residual power. Rohit, you was 20.
I think.
Yeah.
I think the choice of IOL is also very important, and we are yet to get the LAL lenses. That would be a game changer, where we would be able to titrate after some time. And then if we find that the aberrations are more, then small optic intraocular lenses can also be tried. But those are also, something which need to be explored. Dr. Amar Agarwal advocates pinhole pupilloplasty in those patients who have,
highly aberrated cornea.
Yeah, absolutely. Then the formula which needs to be seen is, we usually go in for the Barrett with the true K and TK. That gives a much better this thing. Yeah.
Thank you, sir. So we'd like to now invite Dr. Haldipurkar, sir, He's a pioneer in phaco surgery and a teacher to most of us, a great mentor and a brilliant surgeon. He's always at the helm of teaching as well as mentoring a lot of us in phaco emulsification. He'll be speaking to us on post-traumatic cataract surgeries.